pleasure to present our initial data from our first implantations. We started in May this year, so with measurement we have to fear and what maybe this device can tell us to improve or even be better or be similar. And interestingly, it's not a lot of studies around about VSD closure. We found around 46 studies, but only 3 studies have pooled evidence on permanent perimembranous VSD closure. But the success rate is really high in this paper, as the complication rate and mortality rate is low. It's really depending on what study which you're looking for. But as there's a good review from Rao, which is showing that this is really an effective treatment in the majority of the patients, and the residual shunting is decreasing over time from 25 to around 3%. Nevertheless, there's a risk of arrhythmia. It's around 10.6%, and it's also decreased over time. But there's a late complication rate of AV block. That's specifically what we are fearing. So that's what we look for, and most likely it's related to the stiffness of the device, and not most likely to the procedure itself. So, nevertheless, some also have a difference in tricuspid aortic valve function. But overall, the authors are convincing that still there is not enough data to favor the interventional procedure to the surgical procedure. There's also a lack of comparison on that. So that's why some centers, I think, really proceed different in regard to the procedure to decide about interventional or operative or surgical closure. We also try to use the duct devices over time, but still they are off-label treatment because they are still not recommended for the closure of the VSD, especially 801 and 802. But there's a couple of other devices which have to be also being considered to use. And with the new device, I think we have a good hybrid of the 801 and the 802, which tells us more likely that we have a good alternative to close the bigger, or especially the VSDs above 4 millimeters. So that's what I want to share. This is the first case. We did 13 kilo, 2.4 years. We had a restrictive VSD. We thought to be that it is really around 4 millimeter defect. We had a large left atrium and left ventricle. We have diuretic treatment initiated 6 months ago. And we have the measurements of a QP to QS of 2.02 to 1, so let's say, and an LVEDP which was increased. So this is the angiogram. Shows us the VSD. It's hard to define where the VSD entry and exit is in this case because it's a short VSD. Nevertheless, we thought to measure it, and we measured around up over here. It's interesting, really interesting. So the measurements here. We measured around 4.3 millimeters, so we decided about to add a little more on this device, and we took 8.6 millimeters, which you can see here on the right side, implanted. So this device has a disc of 12 millimeters, a waist of 8, and an RV disc of RV exit of 6, and the same disc again. But as we saw here, this was showing us a little more residual shunt. So according to that, we were not happy with that. Again, we evaluated this defect, and then we saw that might be a different defect. We have maybe 2 defects parts, so it's a double committed VSD. And we went through the upper one with this small device, with this current device, and we were not happy with the residual shunting. So that's why we decided to choose a bigger device, which we implanted over here, which you can see on the left side. Let's start again. But still with that, we were not happy because it shows us, again, the same residual shunting. So that's where we went, as you can see here, to the lower defect and tried to implant the device on that side. And that's happened to here. You can see we are now in the lower defect. With the bigger device is a 10.8 device. And then we saw this was decrease of residual shunting, and that's what we were happy with, and that's why we released the device. And after that, we saw also by echo that it is completely closed. Second case, this was the echo, and this was the angio afterwards. So we see again a tunnel of VSD, which is have some good aneurysm, and this makes a chance bigger for us to implant the device and to stay off the aortic valve, for instance, because it's going into the inlet. And the measurement was around 3 to 4 millimeters, as you can see here. And then we decided about to take 8.6 device, and that works well. So it goes through a little faster. Time you can see the angio afterwards, and the echo. Both are really sufficient, no residual shunting and no interaction with the valves. What we see is over here, we have the disc, which is on the right side, a little stretched. We try to develop it differently, we try to manipulate and try to configure it differently, but it was not possible because of mostly all the material, the trabecular and the muscular. On echo, it looks a little more convenient for me than on fluoro, but it stays as it is, and it works well in this case. So the third case, 3.5-year-old, 16 kilograms, is a restrictive VSD. We measured 3 to 4 millimeters on the echo, enlargement of left atrium. We see again significant shunting and an increased LV EDP, and a small, slightly increased diastolic also. Pulmonary pressure or mean pressure. So this is the effect on echo. 3 to 4 millimeters, which we measured, and again we added some diameters for the device choice. 3 to 4 millimeters. Recommended maybe to use a 4 or 5 millimeter. We added a little more according to the prior experience. So we took 8.6. Which works nearly well in this position. We tried to develop again, but we were again not really happy with the residual shunting on that patient. And this patient again also I took from the surgical list. So I promised that we have a good result in this intervention. So I was not happy with the residual shunting even after repositioning it several times again. So I thought about what may be possible. You can see the echo on the right side. And so the question was new positioning or a bigger device. New positioning we tried, it doesn't make a difference on that residual shunting, so we took a 10.8 device again and tried to use it as a better occlusion device and try to put it into the device as big as good as possible. And you can see here we released already, and this is the result afterwards. And this was again a decrease in residual shunting. So for me, it was the better device than the 8.6 before. On echo again, same after or at discharge, there was no residual shunting, no interaction or interference with the tricuspid aortic valve, which you can see here. So we did, again, 6 cases already. In the last case was a small child. We were not successful because the defect was really big, 6.5 millimeters around. We were trying to put the device in, but we were always having a lot of residual shunting and a lot of tricuspid regurgitation. So that's why we skipped that patient. The other was successful. An adult patient also. It's more easy in this patient. We did all from this part recuperate. According to our device choice, as you can see over time, we have a change in this period over here. The patient were mostly postponed to surgery, so we had a discussion always on the patient, what should we do, how should we treat the patient, and the surgeon said we do, and we said okay, we can live with that, but according to the defect size, according to the size of the patient, according to everything, we decided maybe ADO or ADO2. In the current year and this year, I think it's different. We increased our time, our procedures, our interventions, and I think that's what I have tried to develop further on. So what is our learning curve? So the distance to the aortic valve should be around 2.5 millimeters as minimum. But I would say aneurysm increases the chance of interventional treatment. The size the recommendation is not to upsize really much, so it's about 0 to 1 millimeter upsizing. To our patients, our experience, we have to oversize more, 2 to 4 millimeters overall, to have good result according to the single shunt. And the length of the device is really stretchable, it's really functional, and hopefully also over time, so I think the diameter of the device can be stretched about between 3 to 7 millimeters. So what are the wishes? My wish would be to have a PTFE membrane, not only in the device above 9.7 millimeters, also on the device below. And also, as you can see in the prior cases, maybe have a smaller disc on the right side, because if the disc is similar or like a high pressure disc, it may be sometimes a little difficult to place this. And again, maybe the conus can be a little longer for the tunnel shape effects. So this is the first patients from our first European implementation in May 2018. And we are happy to continue with this. And I think, again, also we have also scheduled already numerous patients for this device, and hopefully we have the same success in the patient I presented to you. Thank you very much.
Thank you very much, Stefan. We're tight for time, but